Hello, everybody. This is Professor Al-Hazza. Today I'll be talking to you about systemic diseases in the eye. This is actually the sixth lecture of our six lecture series for your second year ophthalmology block. This is going to be a fun lecture simply because I'm going to be able to show you how the eye is an integral part or organ in many of the systemic diseases. And a lot of times, many of the other subspecialties depend on the ophthalmologist to be able to help them not only in the diagnosis of certain systemic diseases, but actually in the management and treatment of these diseases. So we're going to be talking about non-infectious. I'm going to try to cover the important ones to you as a second year medical student, and I'm going to be talking to you about the infectious. We're going to be picking a couple of nice diseases that I think are important for you and for your career. So let's first talk about a pituitary adenoma. We know where the pituitary gland is, where it sits, as nicely here. And when we have a pituitary adenoma, what do you think is the closest visual pathway to the pituitary gland when it actually increases in size and causes a more or less compression on the visual pathway? As you see nicely here, it's the optic chiasm. So which of these visual pathway will this pituitary adenoma, enlargement of the pituitary gland, cause? Which of the visual pathways do you think? Is it the homonymous, the bitemporal, macular sparing, pie in the sky? Which one do you think it causes? As you mentioned, you are right. It causes the bitemporal hemianopia from that point. Let's talk about thyroid eye disease. Really important. There is not an exam that will not have thyroid eye disease, whether it's multiple choice, OSCE, when you sit for your UCMLE, when you sit for your Saudi medical license exam. Always thyroid eye disease is an important category. So as you can see here, unfortunately, it causes exophthalmos. You can see it here. It causes lid retraction, as you see it here. And again, it causes the proptosis, or what we call the exophthalmos. The eye bulges forward. And when you do the CT scan, you can see very nicely here, it causes muscle engorgement. All these muscles are engorged. And what sits in the middle of these muscles is your optic nerve. So ultimately, it will cause optic nerve damage, which we talked about, optic atrophy. So when you look at all these, the next thing I'd like to talk about systemic diseases is your infections. So syphilis will cause abnormality in the eyes. Toxoplasmosis, as you see here, will cause macular problems, causing decreased visual acuity. Your rubella, as you see here, will cause abnormality in the retina. Your Candida albicans will cause all these white pearls. So technically, these diseases will cause decrease in the vision simply because these systemic diseases do affect the eye. This just shows you a nice diagram of how toxoplasmosis affects your organs. Diabetes, we talked about that before, so I'm not going to be spending a lot of time. We talked about it in visual impairment, but it is the most commonest cause of blindness in the population of working age in developed countries. Unfortunately, Saudi Arabia has become a developed country, not unfortunately that we're a developed country. Unfortunately, diabetes has now affected us as a developed country. The prevalence of diabetic retinopathy of any severity in the diabetic population is 30%. What we mean is anyone that develops diabetes, they will develop diabetic retinopathy. We talked about it. Under visual impairment, it constitutes 30%. And the prevalence of blindness due to diabetic retinopathy is 5%. Actually, here in Saudi Arabia, it has reached 20%. So this is what diabetes, that affects every organ. The most important is our eyes. As I'm an ophthalmologist, it can cause cataract. Remember, we talked about exudates. This is what we refer to as non-proliferative diabetic retinopathy. We talked about that. Here it just shows you the optic disc, your abnormal exudates, your abnormal microaneurysm, and your hemorrhages. And then it can cause proliferative diabetic retinopathy with all this abnormal vessels. You see here all this proliferation and these abnormal vessels. And then if it's not treated, these abnormal blood vessels will cause vitreous hemorrhage and retinal hemorrhage, which causes blindness that we talked about. Hypertension is another important systemic disease that affects the eye. As you see here, the high blood pressure causes damage to the blood vessels, and it's usually due to arteriosclerosis or vasoconstriction. And you can see, unfortunately, the exudates, the copper wiring. It can cause disc edema. It can cause narrowing of the arteries. The cotton wool spots are the hallmark of hypertension. This is why you have to master how to use the direct ophthalmoscope. There are many skin diseases, mucocutaneous disorders, Stevens-Johnson syndrome, pemphigus, elastic tissue, pseudoxanthoma elasticum. All these skin diseases will also cause abnormalities in the eye. And as you can see here with the pemphigus, it's already causing cicatricial eye disease. And this is really very unfortunate. And then it will cause corneal opacity, and then it will cause complete adhesions of the lid to the cornea, which ultimately causes blindness. And then it also causes fundal findings, whether it's active lesions in the macula. Remember, we talked about the macula, your center of your vision, subretinal fibroses, and your angioid streaks. Family history, please always ask about family history when you're talking, when you're managing these systemic diseases of the eye. So ask about any eye problems in the family. Ask specifically about corneal diseases, glaucoma, cataract, retinal diseases, or any other heritable ocular conditions. Family history is important in the proper diagnoses and ultimately the management. Systemic diseases, many chromosomal abnormalities, whether it's trisomy 13, 15, 21, Down syndrome, we know that it causes a lot of eye problems. The eye is delicate also. In addition to your chromosomal abnormalities, the eye is delicate and it's an indicator of poisoning. So a morphine addict will usually have a small pupil. The lead poisoning, vitamin A intoxication will cause papilledema. So remember, the eye is part of your body. A lot of systemic diseases do cause problems. Let's talk about phacomatoses. For those of you that do not know what the phacomatoses is, these are important questions that are usually asked in your OSCEs, in your board questions, in your Saudi medical licensing. They're a group of congenital and hereditary diseases characterized by the development of hematomas in various tissue. So you have neurofibromatosis, I'm sure you've heard about it, tuberous sclerosis, von Hippel-Lindau syndrome, and Sturge-Weber. Really the two that affect the eye is the neurofibromatosis and the Sturge-Weber syndrome. The others do affect the eye, but these are really more common. I put this up for you. Neurofibromatosis type 1. It's the most common phacomatoses. It affects 1 in 4,000 individuals. It's present in childhood. And this is your hallmark. You get Cuffelet spots. In the eye, unfortunately, you get eyelid neurofibromas. These can be mechanical and they can cause ptosis, as we see in this patient. But another important thing is glaucoma. Remember, we talked about it is the thief of sight. It's asymptomatic. So unfortunately, these patients can have glaucoma and you never knew. And the dermatologist or whoever is managing these neurofibromatosis never refers them to the ophthalmology. So always remember to refer to the ophthalmologist to rule out glaucoma. Again, other intraocular lesions and neurofibromatosis are the Lish nodules. And this is an important question, could be multiple choice question or your OSCE. The Lish nodules, very common. They occur in very 95% of the cases. And then of course your cataracts. Remember, this is your lens, it should be crystal clear, and unfortunately, there are some opacities. Then the Sturge-Weber syndrome. Again, they present with what we call the nevus flammeus or the port wine stain, as you see nicely here. It's usually congenital, non-blanching with pressure. The reason I care about this is it is associated with glaucoma in 30% of cases. So for every 100 patients with Sturge-Weber syndrome, they will develop glaucoma. Get them to the ophthalmologist to be treated in order to avoid blindness. Scleritis. Remember when we talked about the lids, we talked about the conjunctiva, then we talked about the episclera. What goes under the episclera is the sclera. That's the white part of your eye. So 30 to 60% may have an associated systemic disease when you have patients with scleritis. Collagen vascular diseases, whether it's rheumatoid, ankylosing spondylitis, systemic lupus, Wegener's, PAN, zoster, sarcoidosis, and it's really bad. Remember when we talked about the white, this is the sclera? What you're seeing here because of the necrosis is actually the choroid. The sclera is so thin that it's showing the choroid. Here it's totally complete, and here again, unfortunately, you actually have bulging of the sclera due to scleritis. Rheumatoid arthritis with peripheral corneal involvement can cause very bad corneal disease, as you can see here. It's circumferential thinning with intact epithelium. Again, it can be acute, painful. Again, rheumatoid arthritis does involve the cornea. Let's spend a minute or two talking about HIV, AIDS. 70% of the patients develop some ocular involvement. That is considered very high. You have, what do you get? You get a retinal microvasculitis, cotton wool spots, as you see nicely here. You can get hemorrhages. You can get microaneurysms. These are the features of the retinal microvasculitis and HIV infection. I can't tell you, I get sometimes I've seen patients who come in because of they're diabetic, and then I see a lot of cotton wool spots, and it worries me. I send them to the social worker. I tell them do an HIV, and interestingly and disappointingly, they have HIV, which they were not aware about. Again, you can have cytomegalovirus retinitis, as you see nicely here. It is unfortunate, it's full thickness, retinal necrosis and vasculitis. And this is really very unfortunate because these patients are totally blind. You can also see tumors of the eye, what we refer to as Kaposi sarcoma, and you can see it nicely here. It is unfortunate because with HIV infection, especially in the 90s, we were getting a lot of patients that had blood transfusions due to hemophilias. And a lot of these patients died because the reason they were taking the blood transfusion is they were taking it in the early 80s or late 70s prior to the HIV being identified. So the blood was not screened. How can you screen for something when you don't know about it? And all these patients developed HIV. All these hemophilic young boys developed HIV, and they ended up all dying simply because in those days, the early 80s, I mean the mid 80s, early 90s, there was no really, the heart was just barely kicking in. So again, we know what the HIV, how it is actually transmitted through sexual transmission, through blood, and last but not least, through needles. So we have to be very, very careful and maintain a good lifestyle. Herpes zoster. This is again a very common, and we've talked about it in my previous lecture. It respects, as you see here, it respects the midline. you have papulovesicular rashes, and again, you have these dendritic ulcers. And again, I highlight it because this is really an important question, and we like to ask it. They can complain about tearing. They can complain about foreign body sensation, and it is very, very painful. So with this herpes zoster, I've explained you do need to treat them. It is considered an emergency, and you must treat them immediately. Let's talk about the anterior segment in systemic disease, Wilson's disease. This is what we refer to as the Kaiser-Fleischer ring. You get copper deposition in the corneal layers, and it's really very prominent to the eye. So again, I can diagnose a Kaiser-Fleischer ring maybe before the internist or the nephrologist knew his patient had Wilson's disease. Cystinosis, again, another nephrology disease. We get what we refer to as these crystals, all these crystalline crystals in the cornea. This is not a normal cornea. Again, they send these patients to me because we can treat them with certain eye medication. Hypercholesterolemia, when a patient has high cholesterol, you get what we call this arcus, and this arcus usually occurs with deposits in the layers of the cornea, and it's just cholesterol. Again, sometimes these patients show up to me before the internist, and I will tell them, please go check your cholesterol level. And interestingly, they come back and they say, yes, doctor, we do have cholesterol. So that we start them on treatment. Your cataract can get affected. Your lens can get affected and develop a cataract. This is very important in galactosemia. So we have to understand the eye is part of the body. So read on galactosemia and what it causes, not only to the eye, but to the body. Myotonic dystrophies. These are, again, are patients who are really debilitated. This is a neurological disease, and they present to us with cataracts that we have to remove and treat. And then Down syndrome, I showed it to you in an earlier slide. We have what we call the brush field spots. You can see them here, all these brush field spots. Again, it's in the anterior segment. With Down syndrome, unfortunately, and I talked to you, I think, about it, they have nasolacrimal duct obstruction continuously, tearing, discharge, and again, we do have to treat them. So you can see the eye is an integral part of the systemic disease. Let's talk about the eye effects on the posterior segment in systemic diseases. A lot of diseases affect the posterior segment of the eye. We say the posterior segment of the eye, we're referring to the optic disc, we don't see the nerve, and the retina, which encompasses the macula, the fovea, and the blood vessels. So let's look at SLE, systemic lupus erythematosus. It causes a really advanced neuropathy. It can cause optic disc pathology in the form of edema. This can be also visually handicapping the patient. Also, SLE causes retinal findings, which I did not put up here. Multiple sclerosis. We know about the multiple sclerosis and what you see on your CT scan, MRI finding with the plaques. This also in the eye causes a neuropathy and an abnormal disc, which can affect the vision. Metastasis. This is really sad. This was actually my patient who had a breast cancer, and she was, excuse me, she was free of this breast cancer for a very long time. She showed up to me just for an eye exam, and oh my God, I saw these choroidal metastases, as you can see them here. Right away, I called her oncologist. They took her back, and they had to start her again on chemotherapy, radiotherapy. So again, the eye can be the window to many of the systemic diseases. Leukemia, again, will cause a really bad retinal hemorrhages, as you see here. Again, this is smack on the macula. So this patient not only had tumor, leukemia, and he was also blind, unable to see due to the blood covering, unfortunately, the macula. So he had a double tragedy. Sickle cell disease. We know about the hemoglobinopathies. Again, it causes an abnormal retinal findings. Actually, as a resident, I was very fortunate that I was able to do a large study on sickle cell disease and categorized it and classified it. Um, and we had an interesting publication. So please always remember, be an academician in addition to being a clinician. And then your hyperviscosity syndromes. This is really very unfortunate. You have these very torturous vessels simply because of your hyperviscosity syndrome. Many a times these patients show up to us not knowing they have any blood disorders. I look into the eye, then I call the hematologist and say, I'd like to refer this patient to you because I saw something in his retina. And the hematologist calls me back and says, thank you, Dr. Selwa. Yes, he has a hyperviscosity syndrome. And because you were able through the retina, through ophthalmology to see that, you actually saved him from having a stroke, because not everybody does routine exams. Dry eyes is another important manifestation of systemic disease. It's very also common with HIV infection or common with any of the immunocompromised. Remember, at many of our tertiary care hospitals, we have a lot of the immunocompromised diseases. So whatever I refer to HIV, I'm also referring to the transplant patients, the chemotherapy patients, the oncology patients. It's really burning and uncomfortable red eyes. It can be, remember we talked before, it can be due to blepharitis or a destruction or dysfunction of the lacrimal glands, and it's usually treated with lubrication. What is this here? This is what we refer to as the Schirmer test. We just simply measure the tear level by inserting these in the eye. You don't have to know. I just wanted to bring it up to you. Marfan syndrome. I cannot tell you how important the Marfan syndrome is to a lot of non-ophthalmologists when they want to write ophthalmology questions in either your board questions and either your any board questions, your UCMLE, Saudi medical licensing exam, interviews. So it's a genetic disorder of the connective tissue, and usually you get a not just a dislocated lens, but a subluxated lens. And I'll tell you, look at this young boy. What is he doing? He's pointing his hands up, right? And temporal, up and out. And this is why, remember this, this is why your lens, you see it here, this is a subluxated lens. This is a dislocated lens. It's not even there. But your subluxated lens, where is it subluxated? It's subluxated up and out, simply as this boy is doing, up and out. So remember that, always remember, your lens is subluxated up and out, supratemporal. And unfortunately, this lens was totally dislocated into the vitreous. Which of the American presidents had a Marfan syndrome? And they might even think he had all the presentations of it. It was Abraham Lincoln, and he had actually Marfan syndrome. All right, let's now speak a minute or so on giant cell arteritis, a very common systemic disease that affects the eye. Usually it's an inflammation of the medium-sized blood vessels. This is your normal artery, and this is your giant cell arteritis. You can see it's truly inflamed. It's related to polymyalgia rheumatica. The vasculitis of the arteries, head and face and eyes are all affected. You can see nicely here the temporal artery. The blood supply to the eye is affected, and patients can have extreme vision loss. You would have to be able to diagnose these patients immediately and treat them, or it is irreversible. What do they present with? It's unfortunate. They present with scalp tenderness, headache, jaw claudication, polymalgias of the arms and shoulders, fevers, night sweats, and weight loss. Nothing to deal with the eyes. You wouldn't even think, this is why they're missed. They have a giant cell arteritis. So please remember, when a patient comes up to you, just simply take your hands, go over the temporal artery that I showed you a photo of, and just touch it. They will jump, they will scream. Right away, please get the ophthalmologist involved. We do an ESR and a CRP. We do a biopsy, and immediately we treat with steroids. And you can see nicely here the optic disc edema, which was very unfortunate, as you see it here. So this is your optic disc edema that occurs because of that. This is the biopsy that was taken that shows the abnormality in the pathology of the vessel. You have to pump them immediately and extensively for 3 days with IV steroids to be able to make this a reversible disease. I want to also talk about myasthenia gravis. Again, myasthenia gravis is another important systemic disease that affects the eye. It's a chronic autoimmune disorder. It's characterized by presence of antibodies. It can affect any muscle. And what are the presenting eye signs? And 50% of the patient, ptosis. Ptosis. Any ocular motility disorders, you have the INO. And what do you think? This is really an important multiple choice question, probably for your 5th year. What differentiates this ptosis, it's one word, this ptosis from any other ptosis that we talked about. Remember, we talked about ptosis occurring as congenital ptosis. We talked about ptosis occurring as third nerve palsy. We talked about ptosis occurring in Horner's syndrome. This is another type of ptosis, but the difference between this ptosis and the other ptosis, the patient will come to me, doctor, I woke up in the morning, nothing was wrong with me. By the end of the day, I developed a ptosis. So the hallmark is the variability. So there is a variability in the hallmark of this ptosis, which makes it different from any other ptosis. There are many syndromes affecting the eyes. I'm not going to go into them because I'm a geneticist and I have a list of 300 syndromes, 300 if not more, that affect the eye. But I just chose you a couple. Usher syndrome, Lawrence-Moulton-Beadle syndrome, retinitis pigmentosa. I just chose you this simply because it's really very common. These patients are obese. They have extra digits in their hand. That's a group of inherited disorders. They have what we refer to as retinitis pigmentosa. You can see it very nicely in this retinal image, showing the bone corpuscles, showing the pale disc, showing the attenuated vessels. And the most important thing with retinitis pigmentosa, and I love the name in Arabic because it's called al-asha layli, which is true. It does cause night blindness, night vision difficulties, which we refer to as nyctalopia. So the only syndrome I'm going to talk to you about is the Usher syndrome, which is the retinitis pigmentosa. So thank you all very much. It just shows you that it is really very important to understand that the eye is an integral part of the systemic diseases. For us as ophthalmologists, we do tend to really examine the eye not only as an independent organ, but we do examine it as part of the more or less whole body. So think of the eye as an important organ. As I showed you in our first lecture, the eye is not only an important organ, but the eye is a window to the diagnosis and treatment of many systemic diseases. For us as ophthalmologists, we do help and we do support and we do assist the other specialities and subspecialties in the diagnosis and treatment. Thank you all very much. This concludes our 6 lecture series. I look forward to seeing you all in the 5th year. I will be there to show you the clinical part of everything I've taught you here. And at that time, you will have 12 lecture series. So good luck to each and every one of you in your multiple choice questions, which did not come out of the 6 lectures I have given you, if you have paid good attention. And I look forward to seeing you all in the 5th year. Goodbye to each and every one of you, and good luck.